All right, we're going to spend a little bit of time today going through some very practical, what I hope will be some practical issues regarding infection prevention and the environment, because we learned a lot this morning. How many of you were able to get up at that just totally ungodly hour? God love you for being there. So we began to talk about what really is a shared vision between the infection prevention community and the environmental services community, and that is we are recognizing that the environment has probably never been more significant with respect to infection prevention than it is now. The problems that we're dealing with are very different from the ones that we have dealt with in the past. And so all the planets are kind of in alignment now where it is beneficial for us to work together in order to accomplish our objective. And our single overriding objective at this point is to ensure that our patients are kept safe, our healthcare workers are kept safe, and that somehow while doing that, we're going to be financially responsible as well. All right, so at present, which of the following do you think represents the greatest infection risk to a patient entering a healthcare facility? Any one? Do you think it's the type of room to which they are admitted, whether or not the prior room occupant was infected or colonized with a multi-drug resistant organism, the length of time existing healthcare workers had been on the job in that particular unit, or the presence of a structured orientation and training process for all workers? So we know that we've got an increasing amount of data that tells us that of all the problems that are going on with patients, if you are admitted to a room in a healthcare facility and the previous occupant was in that room and was either colonized or infected. Now, colonized means that they have the organism as part of their body's normal flora, but it's not causing them to be ill. Infection means they've got that organism and it's causing illness somehow. So it doesn't matter whether the person is colonized or whether they are infected with these multi-drug resistant organisms. They still contaminate the environment. And it's very difficult, even under the best circumstances, to do an adequate job in removing those organisms or disinfecting that environment completely. Very difficult to do that. So we know that the greatest risk is if that person that was in the room before you had a multi-drug resistant organism. So the biggest issue that we are going to have is not only what we're doing in each individual room today, it's what we did yesterday that has an equal impact. So just some facts, some little factoids, that each patient and others, and that includes healthcare workers or anybody else that enters the facility, brings their own ecology with them. You know, on our bodies, for every one cell we have about 10 microorganisms. So one to 10. So our bodies are made up of millions and billions of individual cells. We're made up of tens of millions and billions of individual microbes. So we're just our own little walking petri dish. And we have the organisms on us for specific purposes. It keeps balance in our own individual universe. So we don't have organisms that have to, or all of them have to compete for nutrients, for nutrition, for the ability to have space to grow and develop. And by having that competition, we keep our organisms in balance. There are some things that we do that cause an imbalance of microorganisms. So what can you think that we might do that will disrupt our normal body's flora? Antibiotics. When we take antibiotics, it kills not only the bad germs, but it will kill some good germs and then allows our body's flora to change. So that will cause us to have sometimes very significant problems with our body or with some of our functional systems. So recognizing that when a person comes into your healthcare facility, it's sort of like that old like Pigpen in the Peanuts cartoon. You know, they're dragging their body's ecology along with them. And so the estimates are within about 24 to 48 hours, a patient room will actually mirror the organisms that are in or on that individual patient. So there are the issues about the room actually forming what we call a patina, or a covering, a coating of microorganisms that mirror the germs or the microbes that an individual patient has. So they only have to be in that room for a couple of days before the flora of the room changes, so it mirrors the patient's. Patients colonized frequently contaminate items in their immediate vicinity. So it's not only the room, but we know medical equipment that is in the room also then will have that patient's microorganisms on it. That's why we need to make sure that we realize that sharing at home is good. Sharing in a healthcare facility is bad, unless the items have been appropriately cleaned and disinfected. So that means every time a patient is discharged, the items need to come out of their room that may end up being used on another patient. So things like the pumps, the IV pumps, or a bedside commode, or any the Plexi Pulse items that are used, to squeeze their feet or their legs following a surgical procedure. Anything that has been used on a patient needs to be disinfected before it comes into contact with another person. Now, pathogens are the microorganisms that may cause illness. They can remain viable. That means they can live on surfaces for days and weeks and actually months and sometimes years. We had a very significant outbreak at the University Hospital in Kentucky, and Acinetobacter was the problematic organism, and we found it on items more than a year after the outbreak began. So we were able to do the genetic testing of the organisms and find that it was similar to a patient that had been there a year previously. So if we don't really understand and think critically about the environment, then we're not going to be able to get ahead of the game. We want to be ahead of the wave when it comes to infection transmission. So if the room and the equipment in the room is contaminated, that means every healthcare worker, every person that comes in that rests their hands on a counter or touches the bed or touches the patient furniture will pull their hands away, and those organisms then will be transferred from the surface onto their hands. And they'll stay on their hands and ride around on their hands until they have reason or the ability to come off. Now, hopefully we will either use an alcohol-based hand rub, and the alcohol has a very quick kill effect on those organisms, or we'll go to the sink and use soap and water, use soap to and rub our hands together, and the friction suspends the organisms so then we can wash them off. It gets them off of the skin, and then we can rinse them down the drain. Hopefully that's what we'll do, but if we don't do any hand hygiene and we go into another patient's environment, that's how we move the organisms from place to place. If we touch the patient, then we'll deposit some of those organisms directly on them. If we touch the counter or touch the surfaces in their room, then that's how we mix the organisms, and that's how we move things like MRSA from room to room, C. difficile from room to room, VRE, Acinetobacter, and other organisms. So if we contaminate our hands, then that means also the healthcare worker can contaminate themselves. So if I have an area of skin that maybe I've got a rash or maybe I've got a scrape, and I use my contaminated hand and I scratch or I rub that area, I then can actually take some of the organisms from that patient and then cause illness in me. So I'm motivated to make sure that I use good infection prevention, both for the protection of the patient, but also for my protection, right? So these are some of the very basics of infection prevention. Now, we also know that if we look at patient rooms and we look at the cleaning, that in many respects, the cleaning of the patient environment is not as good as we want it to be. And that doesn't mean that everybody's not doing their best job. It just means that the environment is much more complicated than it used to be. How many of you have been in healthcare for more than 15 years? Right? How about more than 25 years? Can you remember back, 25 years ago, if you walked in a patient room, all you had pretty much was the bed and an IV pole, right? None of the electronics that we had. I remember when we had the first IV pump. You shined a light on it and made the alarm go off, and it had all kinds of problems. But those machines haven't been around all that long. So those were simpler times, and we didn't have the multi-drug resistant organisms then that we have now. So that means that we can't practice the same as we practiced 15 or 20 years ago, that we have new problems of today and new challenges of today. Now, we know if we have inadequate cleaning of rooms after discharging patients with MRSA or VRE or C. difficile or Acinetobacter, that then puts the next patient entering that room at risk. So if we don't do our best work, the next patient that comes in may suffer. If we do a better job with not only cleaning but also disinfection of the environment, it reduces the ability of the patient to become sick due to infection, and especially sick due to infections that involve multi-drug resistant organisms. Now, we know that if a patient has an illness that is caused by a multi-drug resistant organism, it is more difficult to treat. The patient will probably be more seriously ill. They will require a longer length of stay than if the organism were not multi-drug resistant. So again, multi-drug resistant organisms, or MDROs that you may hear it called, that's our problem for today. Most of our problematic organisms are drug resistant. So again, we have new issues, new threats to patients, and ultimately new threats to us and to our family members who may be in a healthcare facility. So if we know that we have a problem, if we know we've got multi-drug resistance, we know that it is able to contaminate rooms, we know that it gets on the hands of healthcare workers and others, we know it can then move to other surfaces on the hands of the healthcare worker, we know that if we clean the environment, we reduce then the number of pathogens or problematic organisms in the environment. So we know that if we do those things, then we'll have better patient outcomes. And all of us, as our job, and I've been a nurse for more than 35 years, I have yet to meet somebody who didn't want the best for their patient. Nobody that I've ever worked with that I know purposefully wanted to harm a patient. And I think that that's most of our experiences. So we know people want to do a good job. We have to help them do that. So part of our role is to ensure that the rest of the individuals that work with us, that we enable them to do their best work. We enable them to do their best job. And that means that somehow we have to gather information. We have to monitor how well we're doing that and then feedback those results. So gathering information, assessing the ability and the practice of those that work with you is important, and then sharing those results with them is important. Otherwise, they can never improve because they will always assume that what they're doing is just fine. Right? If you don't tell me how well I'm doing, I'm going to assume that because you're not saying anything, I'm practicing well and there isn't any need for things to change. So we know we have to monitor the effectiveness. So when we look at that and we think, okay, well, how are we going to impact all of this? How are we going to make sure that we can do our best work, that we can evaluate the effectiveness of our work, and that people understand the why behind what they do? We know there's some great sociology studies that tell us that if somebody asks you to do something and they give you any reason, doesn't even have to be a reason that makes sense, but if they give you any reason that you are more likely to do whatever it was that was requested of you than you would have had they not given you a reason. One of my favorites is that there was a study that showed people in line at a copy machine. And somebody would come up to them and say, can I get in front of you because I need to make a copy? Well, you're in the line to make a copy too, right? So that reason makes no sense. But just the fact that they gave you a reason as far as why they wanted you to change your behavior, which means let them in front of you, that 80% of the time you would say fine. Now, in that little bubble above your head, you may be thinking, you moron, I'm here to make a copy too, but whatever. But it didn't matter. You may have judged that reason, but you still let that person in line in front of you. And so we know that based upon these multitudes of studies in sociology, that if we provide feedback, if we give people information, then we improve their compliance or we improve their adherence. So one way of approaching this is to figure out, well, how do we then gather pieces of information together and gather activities into groups or bundles so that we can say, all right, we want as part of your job, we need for you to do these 5 things. Or 6 things, or however many is in your bundle. And if we give you those 5 things, we give you a reason for doing those 5 things, and we follow up on your performance, that all of a sudden our adherence goes from a very low to very high. And so our thought in working with AHE and APIC together is to begin to explore what would we want to put in a bundle if we were to focus on environmental services activities from an infection prevention perspective. So some of you say, well, I've heard of a bundle, but I don't really know what it is. Well, a bundle is a structured way of improving any process that's involved in a work practice. So the steps are cohesive. That means they work together. There is a scientific basis behind them. We're not just kind of pulling them out of the air because they sound good. They're very clear, and they are without ambiguity, meaning they're not confusing, or they should not be confusing. They should be very easy for someone to recognize, understand, and apply. In healthcare, a bundle is involved in preventing or improving a patient outcome, generally by preventing some sort of problem. So we have bundles, such as bundles to prevent ventilator-associated pneumonia, bundles to prevent a bloodstream infection, bundles to prevent urinary tract infection. But what we haven't had is a bundle that approaches the issues about the care of the environment. And this makes a good opportunity to bring this to you to begin to get your feedback, because a bundle works best if it's actually owned by someone. So if there is some group that says, this is kind of my bundle of activities, I realize that I'm the one responsible for this, then it becomes then your mission in terms of implementation, and then continue to tweak the bundle elements so they are exactly as you think they should be for practice. Because we know that if we say, well, everybody does this, and I want you to think back to your work, if you go into a patient care area and it's everybody's job to make sure the microwave is cleaned in the staff lounge, how often does that microwave get cleaned? Yeah, it's probably like once every blue moon, right? It's because something that is everybody's job is really nobody's job, right? So bundles allow us to assign responsibility. And so individuals then that look at the bundle elements, then if they can see that it's part of their particular work activity, they're much more likely to embrace it and be able to actually get it done. So when we think about a bundle has specific activities that represent what is expected. So it tells you whatever types of interventions or behaviors are necessary in order to achieve the outcome. They're generally simple statements, but they can also have some tools and resources associated with them. So they can have checklists and other such resources. Any kind of bundle, though, you have to be able to verify and measure it. So you have to be able to verify that it was done and then be able to measure how often it is accomplished. And that means that we can go back to look at to see was that particular surface cleaned? How many times should it have been cleaned? 10. How many times was it cleaned? 7. So that allows us to verify some way through a monitoring process and then measure the amount of times, that 7 out of 10 times that it actually was done. It has to also support the ability to enable you to provide rapid feedback. So in terms of environmental attention, we don't necessarily want to say, well, we're going to determine if a surface is clean because we're going to culture it microbiologically. Because that means it may take 2 or 3 or more days before we get a result back. So how many people remember, do you remember what you did 2 or 3 or 4 days ago? I barely remember what I did 4 hours ago. I'm probably pretty lucky if I do that. But there's no way that it's going to be meaningful for me if somebody tells me, you know, Ruth, that surface you cleaned 4 days ago in room 807, well, we got a whole lot of microorganisms back on it, so we really want to go back and think about what you did incorrectly or how you could have done that better. Well, I may have no clue about what I did in that room, so that feedback is not meaningful at all to me. So we have to be able to give very rapid feedback. So that means if you're doing an evaluation of someone, you want to talk about what has happened at that time. So if someone is doing something poorly as part of their job, you want to intervene and give them feedback immediately. You don't want to wait till their evaluation 9 months later and say, remember back in February when you were late for work? They're going to say, February? You know, it's September. I have no clue about what happened in February. So we want to be able to assess it and evaluate it in real time as far as much as possible. All right, so when we think about a bundle, then we have to try to figure out what are the expected activities. We have to focus our expectations, exactly what we want to see accomplished from these activities, and then can we measure them and validate them. We really don't provide a whole lot of detail on bundle elements because people may implement it differently. So we may not tell you how to do a certain activity, only that a certain activity needs to occur. And again, it's based on evidence. So we don't have people then that are saying, well, you know, why should we do that? That sounds like a sacred cow. And we really don't know that that has any effectiveness, because then we become distracted and we try to focus on, well, you know, is there evidence? Is it really a sacred cow or not? And then we lose focus of the activity that we were going to do. So I want to give you an example about what some different bundles. I'd mentioned the bloodstream infection and urinary tract infection and surgical site infection and so forth. But this one has a direct implication to you, and this is a bundle that involves Clostridium difficile. Now, how many of you have heard of C. diff or Clostridium difficile? Probably everybody. This is an organism that it used to be known as an antibiotic-associated diarrhea, Remember I mentioned that when you take antibiotics, it has that collateral damage. You know, it kills the bad germs, but it also kills the good ones. And it kills the good ones in our colon, and that allows then this organism, C. difficile, to begin to multiply without any balance. You know, it doesn't have to compete for resources anymore because all the other organisms, or many in the colon, were killed by the antibiotic. So once it begins to multiply, it produces a toxin, and the toxin begins to destroy or disrupt the cells in the colon, and that causes diarrhea as well as other more serious events. So when that person has diarrhea, again, those organisms are out in the environment. You know, keep in mind, you know, if you have a bowel movement, it doesn't just stay right there where you see it, right? That you have other cells then, microorganisms, that are able to come in contact with the environment by a lot of ways that you can just picture in your mind, right? Well, Clostridium difficile is of particular importance because it also forms what's called a spore. And that means the organism itself can do it becomes kind of like what we see with an armadillo. It can curl itself up and have a protective coating. And that protective coating enables it to live on surfaces for months. And it's not impacted by most germicides. In fact, some germicides cause the problem to become worse. So it's become a very difficult organism for us to deal with environmentally, as well as just generally treating the patient. So anytime we find that a patient has diarrhea and Clostridium difficile or C. diff is involved, we know that we've got to immediately put that person in isolation. So our first bundle element is to isolate that person either in a single room or put them in the room with someone else that has the same illness. So we want to group those patients together and then try to keep them from coming in contact with others that are not infected. We want to look at their antibiotics and then stop antibiotics if we can, because that may be causing the problem or making it worse. We need to make sure that every healthcare worker around them is using personal protective equipment, and that means gloves and gowns. So we don't want them to have the organism on their hands or contaminate themselves. So use gloves and gowns when they're around patients with C. difficile. So we also know, because remember I told you that when you're in a patient room, it doesn't take long before you've got the microorganisms on all the surfaces. We think of the patient room as an extension of the patient. So that means if you go in the room of a patient that is in isolation and you touch any surface, you now have contaminated yourself, right? So that's why we say when you enter the room, you need to wear the personal protective equipment. That's what you should do. That is considered to be best practice. Now, how many of you have seen people waltz into rooms that are where the isolation sign is on the door and they go in without any PPE? I see it all the time, right? And someone always has a perfectly valid reason, don't they? Well, I'm not going to touch the patient. I have to tell you that's a good intention, but it will not happen. They will touch the surface. They will go over to the patient. And I used to I work with a lot of medical students. I used to tell them, okay, I want you to do this. So I just want you to put your hands under your arms. And I'm going to watch you. And if your hands come out from underneath your arms, I'm going to staple them there. I'm going to get out my big stapler and I'm going to staple your hands under your arms. Otherwise, I know you're going to be touching that patient or you're going to be touching that surface. They just can't help it. And I also know that they will want to respond to a need the patient has. So they will get drawn into touching the patient or touching the environment. So they may say, well, I'm not going to touch the patient or I'm going to touch the environment. I'm just going to touch their bed rail. That's the patient environment, right? What do we think what are the objects most frequently touched by the patient? Bed rail. What else? Call bell. Telephone. That remote control that nobody cleans unless you clean it, right? Over bed table, right? All of their furniture. So the patient is going to come in contact with that, and the patient is going to be touching their own body, and they're going to be touching the environment around them. So if I had like a big, microscope that I could just look at everything around that room, all of those items are going to be items that the patient frequently touches. Now, what about the items the healthcare worker touches? What are the frequently touched items that the healthcare worker is going to come in contact with? The doorknob, right? Whatever they use to enter the door. Light switches. I hope it's the faucet. Lord, I hope that's one of the dirtiest things in the room, right? right? The bed rails, because they're going to be right up against the patient. Any knob or switch on equipment, they're going to be touching, right? Yep, right. Your computer, your cow. I think we're not supposed to call them cows anymore. I don't know. There must be a, maybe that's not politically correct. I didn't know cows had so much political power now, but we're not supposed to call them cows. But yeah, your roaming computer, the roaming gnome. So right, any kind of those piece of equipment. Right, so you can see that from what we have learned, because the healthcare worker touches their hands to the environment, they have organisms on their hands, they go then to other surfaces, they touch frequently, the patient touches items frequently. So you can see then the importance of cleaning the patient environment, right? You know this better than anybody. With C. difficile, we're going to have a patient in a bed that has diarrhea, that has the organisms not only on themselves, in their bed, on their own hands, and then they are touching all of these surfaces as well with organisms that can survive for months. So we have to ensure then that everybody that goes into that environment also realizes that there's something really odd about C. diff, and that is for some reason that organism is very good about adhering to the skin of our hands. And we've got some early data that show us that even if you are a good hand washer, that you have to use some sort of solvent, like something that will remove ink, in order to get those organisms off your hands. They are so good at adhering. So alcohol doesn't kill them, and you can't wash them off very well. So how will you approach then a patient that has C. difficile? What should you be doing when you go into that patient's room without fail? You should always wear gloves, because the only protection that you have is to make sure you don't get that organism on your hands. So when I teach medical students and I teach nursing students and I tell them, this is really part of standard precautions. And that is to remember, if it's wet and it's not yours, you don't want to touch it, right? And even if it's wet in yours, you really don't want to be touching it all that often, especially if you don't know where your hands were before you touch that. So keep in mind that you have the opportunity to not only transfer organisms from patient to patient and surface to surface. It's important that we keep you healthy also. Without you being able to go to your work every day and do your job, we do not have a secure country, because the healthcare system is part of the backbone for the safety of our entire country. So the bottom line for us is we already know that we had to do a good job. Now we've got to continue to prove that we are doing a good job, and we've got to continue to do a better job as well. So we have specific work practices that we know result in specific outcomes to our patients. So we have to really identify the types of work practices that give us the best outcome. And that helps us then develop competence, or some guides for performance competency. So competent practice is relevant to every one of us, because if we're going to come do a job, we need to make sure that it's a good job, that it's the best job that we can, and that we are qualified both in terms of our knowledge, but also we know how to turn knowledge into action. And even more importantly than that, we know that you're going to be working, maybe you're going to work in a hospital this week, you may be working in a long-term care facility, or you may go to work in a physician office, or you may be caring for somebody at home. So either way, we need to make sure that you are capable of transferring knowledge from setting to setting. And that means that you then need to understand the basics or the concepts or the why behind what you do. That helps you then determine and impact your competence. So I just want to ask you, is this practice critical to infection prevention in your setting? Is the selection and use of personal protective equipment important? Is it critical to infection prevention in your setting? How many think yes? All right, so we know that knowing how to select what type of PPE we need and then using it correctly. That means, how do we put it on? How do we take it off? In what order do we put it on and take it off? And then what do we do with it once we have taken it off? So how do we dispose of it? All right, what about selecting the appropriate solution to clean and disinfect a surface? Is that critical to infection? Yes? Right, so we know that certainly is. What about the technique that you use? Is technique important? Is that a yes? All right, so all of these we know are essential. And I love this because I spent a lot of time on an airplane, and this poor guy, it says, fumbling for his recline button, Ted unwittingly instigates a disaster. So he flips the switch to make the wings fall off of the airplane. So the point here is that if we are going to help ensure that people in our workplace are able to do the job, we have to remove all these kind of pitfalls for them. So don't set up a work practice that allows them to be unsuccessful. So we have to think now, how are we teaching our staff? How are we evaluating the effectiveness? And if there's a gap, if we find out why is it that somebody always makes the same mistake, it's probably not the person. And we know most of the time when errors are made, it's not the person. What is it? Right, it's the process or it's the system that is enabling them to make this error. So we've got to look at our work practices and figure out what happened. So instead of us wondering, how did this person make it through orientation? How in the world did they ever get that license, or how did they ever achieve that certification? When really what we need to be thinking is, what needs to happen in order for them to be successful or to work more effectively? So instead of judging the person, we need to be evaluating the process. So all of you, I'm sure, have gone through some measure of leadership or management training. And one of the things that is always pushed is you separate the person from the problem, right? So we don't want to deal with that particular person. We're looking at the issue, what is not happening or what is happening, and then focus on that and not the person. So we don't say, you are lazy and you are mean, or you can't get along with anybody, or you never get your job done, or you never do what is asked of you. What you want to do is focus on the situation and what occurred. And that way you take out all of the personal approach and you focus on the actual activity. All right, so if we think about doing those things, and we think about then adding practices that are going to be important to us, then we need to make sure that if we do these activities, we have to be able to demonstrate competence. And competence means that we have acquired the knowledge, so we understand it, we have a skill, we can do something, and we have the ability, so we are able to do that which we learned. We're able to do it at a level of expertise that is sufficient for the task at hand in our work setting. So in healthcare, it means that we're able to perform our job responsibility in a manner that prevents infection. So we want to make sure that all of our staff is competent. So competency is taking knowledge and skill and ability and putting it into action. So I can't test your competence just by asking you a question. Or I don't say, tell me so I know that you understand. I can't really assess understanding. I can't see your ability to actually apply that and put that into action unless I see you do something, unless I see you perform a task, or I actually see you doing some activity. So when your job is very much hands-on, then we need to make sure that our competence is very much hands-on, and how we determine success is hands-on. So a practice competence in our area is going to be a focus on what the personnel is required to do in their workplace. And we ask them then to transfer that knowledge and that skill into some kind of action within a situation. So it integrates knowledge about the subject matter, a particular skill, their attitude, not whether they've got a good attitude or not, but it's just, are they able to do this, and can they apply it in their work setting? And do they have judgment that enables them to make the right types of decisions? And again, we have to measure it and be action-oriented. Now, I know that you're going to say, oh my gosh, do I have to learn anything more about competence? Well, I'm getting to that. So we're almost done with the background that I want to make sure that you have a firm grasp of before we start to get to some of our practice implications. Now, I love this picture. This was a poster that was presented at a meeting almost 10 years ago, but I think it's very relevant. This is a picture of an intensive care unit, and the X's, the green X's, are particular surfaces in this room where the room was cleaned in its usual manner. Then they went back and cultured these particular surfaces to see what they could identify. And in every one of these green X's, they identified an organism that was present in the patient that was there before the room was cleaned. So it wasn't not only was it the organism that they found, but actually they took the swab where they identified the organism and they were actually able to grow it. So that means that the organism was still alive. It was still viable. So even though this room was cleaned, all of the surfaces that had the X continued to have viable organisms on it. So this is really the genesis of where we began to think about those frequently contacted surfaces. Right, so you can see all of these items are things that are going to be touched either by patients or healthcare workers on a regular basis. So this study about 10 years ago was the first knowledge that we had that rooms can be persistently contaminated even though we've done some cleaning. Now you may say, wow, well that's only an intensive care unit. Surely our regular med-surg areas are not going to be that bad. Well, we know that they are because this is much more of a typical room of today, isn't it? Where it doesn't seem like there's a lot in it, but still there are a number of surfaces that are in this. The beds are much more complicated, many more parts to them, many more places to touch, and more difficult to clean. Even the overbed table doesn't have a lot of just flat surfaces. There are a lot of places that you need to clean additionally. At the head of the bed, many more items that are going to come in contact with the patient or healthcare workers, even though they are on the wall. Look at the bedside table. Many more parts. I'm sure there are drawers underneath there that slide out as well. So the care that we have to give to the environment requires that our housekeeping, our environmental services staff know about all the surfaces. They understand the places where organisms are more likely to hide, but that they also have adequate time to do the job. So in the old days when we could clean a room in maybe 15 minutes, how long does it take us now on average? Yeah, you really need to have about 30 minutes, right, to clean, right, in order to adequately clean and disinfect that room. So if you're being pushed to get patients in, if you're being pushed about throughput time, meaning how long from discharge to when the room is ready to occupy again, that it's really important that you keep your eye on the beacon. Your mission, your responsibility is to ensure that that environment is safe for that patient to enter. So you have to just flat out tell people this room has not been completely disinfected, and that we have to figure out ways then to enable you and the supervisors and other people that you work with to be able to influence then your system so that you are allowed the adequate time that you need to perform this critical service. All right, now I want you to grab the paper that I had at the back for you as you first came in. We worked on a study with several members from AHE to help us look at what are the types of activities that we need to make sure all healthcare workers know so that we can make sure that infection is prevented. And so these competencies these are not designed only for environmental services personnel. This is for all healthcare personnel. So we've used this as the beginning basis for development of some competencies for you to begin to take a look at, and you'll see how we have refined that a bit for environmental services practice. But we need to make sure that every healthcare worker understands the role of microorganisms in disease. So this means we need to make sure that every environmental services worker realizes that if we don't have an adequately cleaned room, that the result can be the transmission of infection to the next patient that occupies that room. They need to know how organisms are transmitted in healthcare settings. So making sure there's an understanding about high frequently touched surfaces, items that are in the room. What are the issues about involving cleanliness versus disinfection? What is disinfection and how does that differ from simply cleaning a room? We've got to make sure that there is an understanding about standard and transmission-based precautions. So all staff understand that when we have a patient in isolation, that means everybody needs to practice isolation precautions, and that we don't ask any individual to judge whether or not somebody else is doing it correctly. We just want you to do it correctly. So here is our standard of a way for approaching that, and we hold you accountable within your job for using personal protective equipment in certain manners. So we don't want you watching what other people do. We want you to sweep your own doorstep, as we say. So do what is important for your job. On the back, we also want people to be aware of occupational health practices that influence the transmission of disease. So we want to make sure that you understand things like, what do you do when you run across a needle? What happens if you get stuck with a needle? What are you supposed to do? What about the disposal of certain types of waste? What if you come in contact with blood or body fluids? So we want you to know what your response should be, both in terms of prevention, but also if that exposure occurs, what are you supposed to do? So that affects occupational health practices that affect you. Well, what about occupational health practices that affect the patient? So I want you to think about and tell me, what is one thing that you do as an occupational health or an employee health function that protects your patient? You should probably be getting ready to do it pretty soon. Flu shot, right. So that influenza immunization, we have tons of data that show that patients acquire illness from healthcare workers. So I'll just do a quick infomercial about influenza. That we know that if you don't take your flu shot and you come in contact with flu, you will probably become infected. Influenza is a very contagious disease, and if you are not immune, you will get the disease. It may not be this year, but it will be at some point. You will get that disease. We also know that about 50% of the people who have influenza are relatively asymptomatic. So you may be somebody who says, I will never go to work sick. If I'm sick, I stay home. Okay? Well, that would be great, but if you're sick on Wednesday with influenza, you are infectious on Tuesday. So that means you went to work, you may not have been feeling bad yet, but you were infectious the day before. Even if you don't have symptoms, you still are able to transmit that. So the only way that we know to prevent influenza transmission is by immunization. We know the vaccine is very safe. We know that the vaccine is very effective, that even if we look at years when we've had a poor match between the vaccine and the circulating strains of influenza, we know that still the vaccine prevented you from developing the most serious forms of influenza. So I hope that if you are somebody who's always shied away from the flu shot because you thought the flu shot could give you the flu, let me tell you that it doesn't. It can't. The shot is a dead virus. It cannot cause you to become ill. You may say, well, when I take a flu shot, for about the next day, I just feel badly. That may be true. About 1 in 100 people, their bodies actually give them a sign to say, I'm using that flu shot to develop antibodies, so I'm working for you. That's what you are feeling. It is the effects of your body producing antibodies. It is not an illness. You can't get sick from that. You can't cause others to get sick. It's simply your sign that your body's giving you that you are producing antibodies. So I hope that you will reconsider and make sure that you are immunized against influenza. Your patients depend on you to do that. They depend on you for their safety. All right, we need to make sure that we have a competency that says we're able to problem solve. That means we can figure out what to do in difficult situations. So, for example, if you go to a fill station and you're going to be mixing your germicide and the fill station is empty, what would critical thinking cause you to do? Go to another fill station, right? You wouldn't say, well, I got some water to clean with. I guess whoever was going to fill the fill station should have done it, and so I guess that means it's okay for me to clean without a germicide today. That's what somebody without critical thinking skills would do, right? And you know that you have people in your department who will do that, right? I mean, we know that. Not everybody has good critical thinking skills. So if we recognize that, then your leadership critical thinking skills are going to be, I got to figure out a way to make sure that that darn fill station is never empty. Because if it is, someone will use water to clean instead of a germicide, right? So somebody with critical thinking skills will go to a different fill station and get their germicide and make sure that the appropriate person is alerted to actually fix that situation. So that's a breach in infection prevention, right? So if we identify that, then we've got to fix it. And then we also realize that we need to have some eye toward general preparedness. That doesn't mean that we have to be worried necessarily about bioterrorism or pandemic influenza, but it means that we need to understand that we may have a flood and that may interrupt our ability to have the right supplies and equipment. So I need to know what to do if there is an emergency. I need to know how to continue my job and to know what my resources are and how to make correct decisions that are going to protect me and protect the patient. All right? So that's just a review about some practice competencies for general healthcare workers. But now we want to think another step a little bit closer to your world, and then think about what sort of practice competencies do we need for you in your job. So again, we looked at what an individual needs for infection prevention, and that is the roles of microbes in disease, how is it transmitted, what are the precautions I need to use like PPE, what are the occupational health practices I need that will protect me as well as the patient, how do I use critical thinking skills to solve problems, and then how do I make sure that I have an eye toward preparedness because disasters happen, come in all sizes and shapes. But we're going to take that a step further now and begin to think, and I want to give you a particular situation. So we have a 64-year-old male that's admitted to your facility. He has a history of MRSA, and that was identified during a prior hospitalization. He comes to your hospital. We don't know about his MRSA status, but we go ahead and put him in a private room because we're waiting. Maybe you're doing surveillance culturing, or maybe it's just your hospital's policy to put somebody who had a prior MRSA result in a private room. And he's a really popular guy. He's got lots and lots of family members that are going to be coming in and out of that room. So when you think about that patient, and you want to think that, will your practices with respect to that patient differ if this patient is in isolation? Will you do something differently for that patient? How many will? Right, so what are going to be some of the things that you'll do differently for that patient? Right, you're going to make sure that you use PPE when you go in there, right? You're going to want to make sure that PPE, if you use the last of it, your critical thinking skills are going to be to make sure that it's some are there for the next person. But is that for the patient or is that for you? Right, that's more for you, right, than that patient. So what we want you to assume is that every patient has some sort of organism that we don't want to share. So our activities in that room will be the same unless we are given a particular reason to do otherwise. Will you use the same germicide for that patient whether they're in isolation or not? Will you switch a germicide? Use a separate one for MRSA than for others? Not everybody does. Some places. How many do? How many use a different germicide for MRSA? How many use a different germicide if this had been C. difficile? Yeah, oh, I'm really happy to see that. That's excellent. So we know then that as we learn more about microorganisms, there may be some things that we do differently, but maybe not. It's not, we don't have a lot of clear cut, but there's still a lot of ambiguity or uncertainty in our activities. And that's because we have a lot that we don't know. We do know that in any healthcare settings, we have organisms like MRSA, VRE, C. diff, Acinetobacter, the gram-negative organisms. Acinetobacter is one, but we've got many others. And then we have the patient, and we have a worker, and we have the environment. And there'll be interaction between all of these. Will be a lot of interaction between the patient, the worker, and the environment. So just like I mentioned earlier, we're going to touch surfaces and we're going to touch other items, and all this interaction is going to occur constantly. So that's why we have to clean the room repeatedly, right? That we're constantly reducing the organisms that are on those surfaces so we can do a difference. So if we think about organisms that we know are of particular environmental importance, MRSA is one, VRE or vancomycin-resistant enterococcus is another, Acinetobacter is another, C. difficile. These are all organisms of importance. Why are these important? Because if we transfer them to another patient, it causes them to become sicker. Drugs used to treat them are more toxic and problematic. If we pick the wrong drug and don't start the right drug quickly, that patient is liable to get sicker faster, and their mortality rate or their risk of death goes up. We also know that they are very environmentally hardy. They like to live on surfaces for long periods of time. So, for example, MRSA we know is viable generally from 2 to 9 weeks. VRE for up to 12 weeks. C. difficile, 5 months, but up to a year. It has been identified in environmental surfaces. Acinetobacter, 3 to 5 months. At my facility, we found it 364 days after the start of the outbreak. Serratia, maybe 2 months. The hepatitis B virus, that's something everybody worries a lot about, can survive up to a week. HIV, 3 to 4 days. Norovirus, a huge problem, especially in long-term care facilities and cruise ships, if you like to go on a cruise. Norovirus can survive up to days on surfaces. So Again, the environment in which we live and work is much more problematic than it has been in the past. So we have to realize the importance of these organisms and then figure out how are we going to approach them. Now, unfortunately, we don't have a magic bullet. So it doesn't matter what we hear about all kinds of different pieces of equipment, all kinds of different surfaces and surface materials. There simply is no magic bullet. So we have to figure out how do we continue to do the very basics, and that is we have to clean and physically remove the organisms with an agent that is going to allow disinfection of the surface. No one germicide addresses them all. So that means we need to have not only our routine plan A, but we've got to have plan B. So those of you that raised your hand that said you do something differently for C. difficile, in order to make that work, you have to make sure that you've got a plan in place and that somebody has tested that plan to make sure that it works. So if you have written in your policy that you are only going to use, I'll pick a bleach, that we're only going to use a hypochlorite solution when we identify C. difficile, and you never test your process to ensure that it works, then Friday afternoon on a holiday weekend, you're going to have that laboratory result, and you're going to have to implement then a change in your practice. How likely are your staff going to be able to be adherent and do the job that's necessary if you haven't practiced that plan? Probably not very, right? So you need to make sure that not only you have a policy written or a procedure written, but you've tested it to make sure that it actually works. You also need to make sure that your workforce knows when they need to make a choice. So if I need to select a different germicide, if I'm using a quaternary ammonium as my primary germicide and I need to make a change, do staff know what those triggers are? When do they make the change? And then how do they do it? How will that change their cleaning practice? Do they know those things? And how do you know that they know those things? Have you tested that change? Have you monitored their ability to make that change? Have you provided them with feedback so that they know how well they did so that you can change the system? Adequate use necessitates a close work between leadership and the workforce. So that part of the job of leadership is ensuring that staff are able to do their jobs. So not that they can, not that you tell them to, and not that you have it in writing to guide them, but actually are they able to do this? Now I have just a demonstration of sometimes we actually undermine ourselves and we disable our staff from doing things. So I want you to look at this row and I want you to tell me the colors in row 1. Red, blue, green, yellow. I mean, that's pretty easy, right? What's the second row? Yellow, red, blue, red. Well, our brains can pick out those colors. So what happens then if we substitute the colors for words? How well are you able to do that? Red, blue, green, yellow, that's a little light up there. We can do it, but our brain is processing that a little bit differently. Well, sometimes we disable our staff from doing the right thing because we mix them up. Now, I want somebody to read that first line for me as quickly as you can. Yeah, there's like, wait a minute, I said the color instead of the word. That our brain has a very difficult time processing when the color and the word, when there is a disassociation. So when we do things like we use color coding inconsistently, then that disables our staff from doing things correctly. It also points to the importance of color coding whenever possible. So as you are developing training materials, if you want them to use the germicide with the yellow label, then it really helps if the directions are also in yellow, so people can match those two. Why else do you think color coding might be helpful? Because we've got an illiteracy rate that is anywhere between 25 and 40% among some of our age populations. If your facility is like mine, also we know everybody that is working in my facility was not born in the United States. Therefore, they may not have grown up with systems like I have. Their system may be totally different. We also know that we have some very distinct cultural differences. And I'll give you an example. I was in a healthcare facility. We were looking at an outbreak. And I was going through their processes with them. And just in the evaluation, we learned that they had some staff members that were of a particular, very strict religious order. And they had females working in the environmental services department. And part of their culture was that they were not allowed to ever see the body, any body parts of a male. And so when they cleaned the room, they always had their back to the patient because they didn't accidentally want to see something that they shouldn't. So how able were they to clean all of the surfaces in that room? They were not, right? But nobody thought about that and nobody realized that. It wasn't until we were in the midst of just a raging epidemic that when we began to observe practice, we saw that only certain parts of the room were being consistently cleaned. And that when we began then to talk with individuals, then we had people say, oh yeah, I did notice that. I didn't put it together, didn't put two and two, but it is kind of odd that I never actually saw that person look at the patient. And that all they were cleaning was the outer surfaces, but never touching the bed. So that bed, unless it was empty, was never actually cleaned. So was that person wrong to do that? Well, this was part of the way that they were brought up. This was their religious belief, and so it didn't seem wrong to them. It's just that we didn't do a good job in training, in our orientation, because no one actually observed them going through that cleaning process in the real world. So we had them in a simulated setting. They could do everything in a simulated setting where there was no patient. But once the patient was in the environment, we didn't watch and observe practice. So it really points to, are we enabling our staff and are we recognizing these barriers so we can get things done? So whether it's color coding or whether it's evaluating work, make sure that people are actually able to get that done. Now, what I showed you with the color coding actually has an evidence base. It's called the Stroop Effect, and it just shows that our brain, in order to understand, needs a relationship between what it visualizes and what it reads. So those things need to match. So putting colors and words together are very powerful. It locks people into decision making. When we separate those two or we introduce any confusion, we cause a lot of not only anxiety, but we really prevent people from being able to do the work, and it slows them down tremendously because they are trying to pull away the color from the word and then process what that difference means. So enable people, use some of these simple tools to do the right thing. Also, I love this particular slide that was put together by a colleague some years ago, and it just actually describes the issues that we have now with our workforce, that everybody doesn't learn the same, right? We know we can't use the same methods to teach people, that we have those that we call the mature people. Those were the ones that predate the baby boomers. These are the people generally that fought in the wars. They were hard workers. They have a real sense of duty, sacrifice, thriftiness. And I mean, when I say wars, I'm talking about the big ones. You know, we talk about the world wars. The baby boomers are those that are just now beginning to turn 65. We've been described as those that are a little bit more selfish. We're into personal fulfillment. We're sort of optimistic. We are crusaders for a cause. We do buy now and pay later. That's probably why we're in the midst of some of our credit issues. But we're pretty efficient workers. Whereas our Gen Xers, they're not so great. They're very focused on themselves. They live for today, but they tend to be savers. So those that are born in that 65 to 80, those are the ones that, you know, they've got these internet savings accounts and they are much more attuned to what's going to happen to them tomorrow. But they are very much in trying to get rid of tasks that they feel as unnecessary. So don't have me do something just because that's the way we've always done it. You need to be able to justify to me why I'm actually doing it, and is it important enough for me to do, and I want to be involved in that decision making. Well, now we've also got the millennials. These are the youngsters that were born in 1980 and on, that they want everything done on their terms. Just because they're scheduled to work tomorrow doesn't necessarily mean that it will work for them. You know, that schedule may not be them, so they may or may not show up. They earn to spend. But these are also the people that have watched their parents, the baby boomers or even their grandparents, lose their jobs, lose their pensions, be the victim of theft by their employers. So this is not a trusting group. So they are not likely to do things out of the greater good and not likely to do things because there will be some benefit for them in the future. They are living with what they have seen, the actual life that they are experiencing. So they are much less likely to respond to you as their boss or respond to rules and regulations as have prior persons. So that means your approach with them has to be very different. So oftentimes if I'll do orientation and I'll have new people that are sitting on the back row, they're sound asleep, their heads drop back, they got the little trout mouth that's open, maybe like that little bit of drool going down the side. And while I'm talking about infection prevention, these are likely to be these millennials, maybe a few Gen Xers, but I have not established any kind of relationship with them, and they have no value for what I'm telling them. They don't see that it is relevant to them, and they will wake up when something is relevant to them. So that means I've got to figure out what is it that they need, what's in it for them, how can I approach them, and how do I train them differently. So if you have one way of teaching all of these people, then you are likely to be unsuccessful. And these are, if we think about, these are all general Americans. What about all the people that are coming into our country that are from a completely different culture, maybe don't even speak our language, but we're having to adjust to their needs, their life situation, and know where they're coming from as well. So I think the bottom line is that our approach to staff development and training has to be very multidimensional. And then we have to realize that our workforce is presenting us with new challenges, and so we're not going to be able to do things like we did in the past.